Good morning. Thank you very much for coming. We're excited to have you here. My name is Dexter. I'm the Assistant Commissioner at the New Hampshire Insurance Department. We're going to share a video from DJ Bettencourt here. Unfortunately, I'll let him speak for himself. Unable to make it today. We've got a short 4-minute video from him introducing what we're doing here today, and then we'll have another video a little bit later from him, and in between, some good stuff from Jason Aziz. So why are we here? We're here, this is an inaugural forum that stemmed from an idea DJ had probably 7 or 8 months ago. Maybe we could do a couple of things. And with the goal of sharing high quality healthcare metrics with stakeholders. I see you in the room, legislators, lobbyists, industry people, everybody's here. We want to provide some information. And then talk about that connection between society-wide healthcare expenditures and the costs that consumers incur. So we're going to talk about that, and then hopefully provide some insights to help inform policymakers when they're trying to balance the interests of both industry and consumers. So with that, I'm going to give it to DJ.
Good morning. My name is DJ Bettencourt, and I have the pleasure of serving as the Commissioner of the New Hampshire Insurance Department. It is a pleasure to join you, and I want to thank each of you for taking the time to join this important conversation. I want to express my regret that an unexpected family matter has prevented me from joining you in person today, but the show must go on. There's a simple idea at the heart of today's forum. If we want a system that works for Granite Staters, we have to understand how it works, and we have to be willing to talk about it openly. In healthcare and insurance, that has not always been the case. Too often, we talk about rising premiums in one room and the underlying costs in another, as if those two aren't directly connected. Today, we're bringing those conversations together. The purpose of this forum, again, is straightforward, but important. First, to give a clear data-driven picture of what is actually driving healthcare costs across our system. Second, to connect those cost drivers to the rate filings that will soon come before the department for the upcoming plan year. And third, to do all of this in a way that is transparent, so that policymakers, market participants, and the public can see in plain terms how these pieces fit together. This work is grounded in our responsibilities under New Hampshire law, including our duty to collect, analyze, and make healthcare data available in a way that serves the public interest. But beyond the statute, it speaks to something larger, the belief that people deserve to know how their healthcare dollars are being spent and why. You'll hear today about the total healthcare expenditure. Now, that may sound technical, but the idea is simple. It's an effort to take a comprehensive look at what we are spending on healthcare in New Hampshire and where those dollars are going, whether it's hospitals, outpatient care, prescription drugs, or the administrative side of the system. It's about taking a complicated system and making it just a little bit more understandable. And the timing of this forum, it's no accident. By holding this discussion ahead of upcoming rate filings, we are creating an opportunity through transparency to bring a greater sense of accountability and understanding to the process. When we can clearly see which services and trends are driving costs, we are in a much better position to evaluate the rate changes that follow. Now let me be clear about the role of the department. We are not here to dictate outcomes or step outside the legal framework that governs how we do our work. But we have tools, and good ones. And one of the most effective tools we have is transparency. When information is clear, when it's shared openly, and when it's understood, it has a way of encouraging better outcomes across the board. There's also a broader purpose here. When we bring this level of data and analysis into the open, we're helping to build a stronger foundation for decision making. Whether that's a family choosing coverage, a provider thinking about care delivery, an insurer managing risk, or a policymaker considering reforms. Good decisions begin with good information, and that's what we're working to provide. I leave you with this. No single part of the system is responsible for the challenges that we face. Healthcare costs are driven by many factors: how the care is delivered, how it's priced, how it's used, just to name a few. Addressing those challenges requires all of us to be working from the same set of facts and be committed to finding practical, responsible solutions. That's what today is about. So thank you for being here, thank you for your engagement, and thank you for your commitment to getting this right for the people that we serve.
Good morning. It's so nice to see all your smiles, your beautiful faces, and I'm blessed to have the privilege to be able to stand here in front of those smiles. And I'm also proud to be standing next to that right there. So thanks for sharing this opportunity with us. I wanted to echo the message from Commissioner Bettencourt, and I regret him not being able to be here with us today, but he's here with us in message and in spirit. But he talked about transparency and the role of the department and the role of this important information that we're about to present to you under the guise of transparency. And I think that's an important part of the work in the missive that our executive team has given to our data analytics unit. And we take that missive seriously. We want to share information so all people in the markets, people in industry, consumers and citizens, and also important legislators who make the policies that affect our healthcare delivery and cost. We want them to have the best information possible, unbiased information that's really transformed responsibly and balanced. To that end, we met with a lot of those entities along the way to get their inputs on how to best and most responsibly express some of the metrics you're about to see. That's a living process. We take that seriously. We actually have an open invitation to all who are present and all elsewhere to reach out to us to find, help guide some of the dissemination of this information so that we can deliver a transparent, a perfect message to all the policymakers. Just keep that in mind, and we have an open door to reach out to us anytime. So this is just some of the background. I'm not going to iterate all that you see here, but I am proud to work in New Hampshire Insurance Department. Under the guise of transparency, this state was an innovator in healthcare transparency. We were one of the first states to develop and invest in, and that's an important word, invest in, because it doesn't come free. It's expensive to citizens, to insurers, and to healthcare providers. Invest in an all-payers claim database. It truly is the freshest, most recent, most sensitive, and most specific set of healthcare data that we have. Morgan Harris sits right here, and Maureen Brooks is somewhere else in this audience, and they work hard every day, and I see it, to make sure that citizens, policymakers, and industry has access to that information. Let's make the best use and optimize the utility of that data. You'll see some measurements that employ the claims data, and in an update of this document that we're about to present, you'll see more of that. And it's 12 weeks old, this healthcare data. Comparatively speaking, that's hot off the press compared to a lot of other healthcare data. If we're going to be making healthcare policies, we want to use data that's reflective of the current paradigm of healthcare. And so that's important, and I'd like you to know that. Now you know that. One of the highest use cases or highest utility use cases for the claims data is New Hampshire health cost. Whereas we recognize some of the opportunities to make it better and more useful for citizens and policymakers and large employer purchases, we also are proud to share that information and the utility of that with everybody here in the room and all the citizens. And we aim to make it better. We get suggestions from the public every day on how to do that, and we have big plans in the near future on how to make it better to serve our citizens. But that's the first healthcare service cost estimator that really public saw, and it's important. Now we've seen policies that encourage other permutations of that, but that's a key use case for the claims data, and it's really important. It's reflective of price exposures or cost exposures that people really feel. These are empirically based. They're from the claims data. Real citizens in real counties going to real providers incurred those costs. And that's important that you understand the contextual relevance of that. And then both today in our fall annual hearing, on healthcare premium and claim cost drivers all employ the claims data and some of the other data sets that we work really hard and invest exhaustively to share that information with you. And pursuant to the Commissioner's words, that's what we're doing here today, is sharing information with you. Commissioner Bettencourt always challenges me, and he gives me, I think, he doesn't really come right out and say it, but he gives me some sort of big word quota, and I think it's something like three big words, and I haven't used one yet, so I keep track of that, and I know others do. And if he were here, he would be keeping track of it. But he said total healthcare expenditures is like a big word, and it's like, it is really, especially when I was first exposed to it, I'm like, whoa, that's a big word, what does it mean? Because we sometimes get that confused with another euphemistic phrase, total cost of care. And so then it begets the question, well, what's the difference? Total cost of care, total health care expenditures. And it turns out there is a difference. And in true transparency, I really forget what the difference is, and it's not really just semantics. There's a mechanistic difference between the two. We measure total healthcare expenditures, which is essentially an additive function of total medical expenditures and the net cost of private health insurance. And if you think about that, what do we pay for when we pay our premium, and then when we pay the out-of-pocket costs that we are all alarmingly familiar with? What do we pay for? If we added it up across the entire New Hampshire population, it would be the value expressed as total healthcare expenditures. So when you think of it that way, it's much less cryptic and really much more purposeful and I think useful to guide healthcare policy. So I wanted to level set with that, and I still have 3 words to use. It's noteworthy that 8 other states measure total healthcare expenditures the exact same way, i.e. using the same methodology that we've used here. And that there are other measures of total cost of healthcare in the nation, but they're more indirect. They use the National Health Expenditure Account data and aggregate that across the entire U.S. population and adjust it, I'm simplifying and paraphrasing here, adjust it for state population representation. So, but it's noteworthy that they're not directly measuring healthcare entities that are endogenously doing business in the state of New Hampshire. So we refer to that distinction as direct measures of healthcare financial activity in our state. So those are 2 key things I wanted to point out to you. I thought much of publishing methodology in our own words, and then I thought, why? Michael Baylett from Baylett Health really cast the die on delineating what the methodology to do this is and how it best be standardized across the states who endeavor to do this. And that standardization, 1, is very important. 2, we take very seriously. We had countless examples when deriving our model where we had to make decisions. And we were very cautious when we encountered those conditions because we did not want to deviate from the standard methodology. For every incremental unit of deviation from that stepwise approach took us away from the sensitivity and specificity that all the other states, those 8 other states I was talking about, that their data had. And what the consequence to that is you lose the comparative ability of those metrics. We always get that question, well, how are other states doing, or what are other states doing? So because of all of those reasons, it was really, really important that we adhered very closely to the Baylett methodology. I just merely put a reference up here, and we'll share these slides as a PDF with you so you can access this. And now, I think we live in the age of information. You can really just Google AI and said Baylett total healthcare methodology, and you would get right to that site. It's exquisite despite its simplicity and its standardization in all of the approaches to do what we're aiming to do here. And I'm going to get to it sooner than later. And this is a graphical representation. My background is biostatistics, and I love me a good equation. And I really thought my team members, who are much more brilliant than I am, would have appreciated that, but they all pretty much agreed that that equation, Jason, is really awkward and it's too confusing. And Matt Jeffrey, who's here, really convinced me to get that out and put a flow chart in. So a picture is indeed worth 1,000 words, and that's the model right there that we're using. We simplify it right here. It's total claims, what we spend on healthcare. That's pretty easy to understand. And there's an administrative cost to healthcare because there's infrastructure that's necessary. You add them together across the population, and that equals what we spend. And it's important for us who work on this and get deeper and deeper in the weeds, so to speak, to always turn back to look at this. What are we measuring and how are we measuring it? You're about to see that now. So the first and hardest step, and when I mean the hardest step, it accounted probably for over 90% of the time, effort, and frankly stress of it all. And because it turns out that there's a lot of heterogeneity with regards, there's one word, I'll use one, with regards to data governance. That means it's different. We have different authority to collect data on all of these payers. Traditional Medicare, then there's Medicare Advantage. There's two distinct sets of authority that might otherwise govern your ability to ask them for the information to compose this model. New Hampshire Medicaid, we don't have any direct, the insurance department per se doesn't have direct authority to derive and publish that data. We had to coordinate that. In the commercial market, where our authority seemingly is the strongest, it exists in the commercial fully insured market. That segment of the market affords us the greatest confidence that that is the most precise, accurate, and unbiased information in the model. But then there's the commercial self-insured, we like to call them the ERISA plans, which reflects greater than 50% of the commercial market, which is the majority. And that's no trivial undertaking to try to get that information. And we have actually a cascade of different instruments that we employed with great rigor sometimes to optimize the representativeness of the commercial self-insured market, because that's a lot of expenditure for which, if we were not successful getting them in the model would not meet the condition of being minimally biased. It would be magnificently biased. But that whole story describes why the first and most important and most difficult and arduous step was doing that. I'm proud of my team's work in doing that because in true transparency, that's not a lot of that understanding exceeds the limits of my knowledge. But we have Morgan Harris, Maureen Brooks, and Matthew Jeffrey, and then other members of our team that are sitting in here today that are masters of that area of the industry. And they put together a very highly representative model, which I'm about to show you here today. And that's what a well-balanced, multidisciplinary, and highly intelligent team can do. And they took that, and our commissioner took that responsibility seriously. We would not sit here in front of you and present this information had we not had the utmost confidence that we had a population representative model of all the healthcare expenditure in the state. So these two graphics are, they're rare examples of how I would ever publish and present a pie chart. Pie charts and me have a contentious history, but they do one thing very nicely. They show partitioning, and with regards to frequency data, what segments of the population from each of those categories I presented in the last slide do we have incurred claims data for? And you can look at these, especially if you've accessed the document digitally, you can zoom in a little bit. You can look at those to see what the proportion of each of those populations are. And if you want to confirm and or challenge those statements that I just made about population representativeness and the sensitivity and specificity of this model, go look at national proportionate estimates for each of those lines of business and see how they closely match up. That was the process that we used to confirm that we were getting closer and closer and closer to that target for optimal population representativeness. That's the key part of the model, by the way, and it's an important part. Imagine if one segment of the market for which cost data gets inputted is underrepresented in the model or overrepresented. That would be a catastrophic flaw, but one which it would be hard for the citizen or the policymaker or any person, even those with scrutinous eyes, to see. But we see it, and we are transparent about the way that we present that. And that's why we take these two slides seriously. This was as an important output in the metrics as the ones that you're about to see about, I hear somewhere drum roll before I open up that slide, because all of this work really goes into making the next slide the most relevant and the most precise and the most representative of what's important to leave here today knowing about. I wanted to talk about missing data bias, where we didn't have incurred claims data for certain lines of business. We used imputational methods to do that. We imputed based on the specific line of business for which those total incurred claims were lacking. And there were some cases where we did have total incurred claims, but they were not segregated or drilled down to the service categories of interest for which we reported on in the model. In those rare conditions, actually, we used imputation of the crude proportions for the specific line of business of interest. If anybody wants more information on that, please reach out to the department, and we'd be happy to meet with you to talk about not only how we did it, but when we did it. But that's important for you to know, because there's just under 1.4 million people that live in New Hampshire, and it's not possible to get healthcare data on 100% of them. And so that's a similar process to how other states, the 8 other states who use the Baylett model, approach that bias. We just wanted to put this reference slide up here because how you define service categories is really important. We rely on standard consensual definitions that for some of the other work that we do and other states do, these definitions vary, the service category definitions. You can see what's in and what's out. And I wanted everybody that looks at the report to have access to that information, because in order to optimize your interpretation of it, you need to know that information. If you want help interpreting that, please reach out to the department. We're happy to. We get lonely after these presentations. We hear crickets a lot. We want to hear your beautiful voices. Inquire and drill down deeper, and maybe offer us suggestions on how to augment these sets of metrics to account for something that you may not see right here today. One note, under professional, those are the good doctors, the good nurses, the physician assistants, my daughter's an LNA, the LNAs, the clinical staff that deliver health care to human beings, some of which are sitting right here in this room. All of our citizens, we call them providers. And that's not an alliterative term, that's the term. They provide health care to you. They're classified in this model holistically. Physician and non-physician providers are all classified together. But because New Hampshire has a rather unique, I think impressive, and broad scope of non-physician provider practice, namely advanced practice registered nurses, physician assistants, and I think even in the behavioral health substance use space, there's a lot of community health workers that can, deliver billable services to our citizens for a lot of these areas which represent key gaps in access, we thought it would be better to bifurcate that category and report it as physician professional and non-physician professional or other professional. So we could get a little bit of a more drilled down sense on proportions. And some of the work that our team did in reporting some metrics for behavior health substance use disorder, you'll see them in slides coming right up. We'll show you an example of why that's important and the types of insights that it casts that are of policy relevance coming at you. The other importance of this, the standardization of definitions, is that enables that cross-state comparison, comma, but with regards to evaluating the fiscal impact of policy. I'm still not wholly sure. My acumen is slowly developing and understanding why it's so very germane. And I think that it is because all the smart people in this room and the other, frankly, brilliant people that I work with at the legislature, they always ask this question. And it's a very mundane question, but what are other states doing? And I could use help understanding the deeper importance of that, but I do know this. When we want to have an objective analysis of the fiscal impact of a policy, ... in that other state, we need to be able to have standard measurement approaches to evaluate that. That I do know. And so that's an important part of the fidelity of us sticking to these standard definitions. And we welcome feedback on it. You can see I'm placing a lot of emphasis on describing that so you have a deep understanding of the importance and the fact that some of these definitions are heterogeneously defined. That's still, I use that word twice, but it only counts as once. So they're defined differently. And we collect these data this way in our fall annual hearing, and that's an example of a difference in the definition compared to how we use them for this model. And that's important. Even within the state and within a state agency like the insurance department, we do have heterogeneity in our definitions. And relying on a consensual definition is paramount to making sure you're comparing things equitably. No, I cannot get myself to say apples to apples because we're not talking about fruit, but we want equitable comparative metrics, and you have to have standard consensual definitions for the raw data to do that. Okay, drum roll in my head. These are the key findings from the model. And it probably took us 90% of the time to derive the population representativeness and 10% of the time in dumb anguish to get the cost estimates. And it'll probably be the same proportion in describing to you our methods to define the eligible population and to define what the summary statistics born from that measurement are. For 2023 on the left, you can see $12.84 billion was spent for total healthcare expenditures and a per capita estimate of $10,700 plus. For 24, you can see it's over 13.7 billion with a per capita expenditure estimate of 11,657. You can tell that I know about our population representativeness metrics more than these metrics right here, because these are not arbitrary numbers. These are numbers that we publish with great confidence, and it's important that we communicate the strength of our confidence in the work that we did, because all you can really see is a table, and anyone can produce a table. I want you to know what went into the production of this table. All those things you heard about. And sometimes maybe a picture is worth 1,000 words. Those are the important numbers. Let's call them out. I'd like you to use these numbers in some of the work that you do in reporting. You know, what's the per capita estimated cost of healthcare for our citizens? It looks like that. These pictures reflect one of my attempts to put into graphical representation the whole market by service category for 23 and 2024 respectively. What's noteworthy, and it may be hard to follow in this output, but on the publication you'd have an easier time, but I can walk you just through it easily. If you look at the categories in the donut, these are called, I don't know why we call these graphs that are very lukewarm, pie charts and donut graphs. Like, maybe we could have some healthier food that we could allude to. But that's my job, I guess, to work on that, because that's, I think, one of my key priorities in healthcare. But they go, the order of the service categories is in clockwise fashion. Inpatient facility is the light blue, and it goes right around the circle. Those are the proportions of healthcare expenditures attributable to each of those service categories, with the absolute value in the middle. Note the absolute value is total medical expenditures. We're ignoring here the net cost of private health insurance, which, just as a note, for the metrics that we publish, on average is about 500, Morgan, help me with this, is it $500 million? $500 million a year. Well, it's hard to say those terms because that sounds like, you should be going like this, like Dr. Evil, but like, that sounds like a big number, but when you're dealing with all these numbers of hundreds of millions and billions of dollars, sometimes they get lost in translation. That's why I have important members of our team here. But you can see what that looks like, and we just highlight some of the key areas for each year that keep turning up as important cost drivers of healthcare premium, total healthcare costs at the individual and the population level. And one of the reasons why they keep turning up, there's many reasons why they keep turning up, but many of those are very important reasons. It's because of innovation. A lot of innovation in healthcare is driving the increase in retail pharmacy. These important drugs like autoimmune inhibitors, anti-neoplastic drugs, some of these CD4 inhibitors, they're treating cancers with injections and infusions, whereas prior to their onset, their innovations, barbaric surgeries and radiation and gross chemotherapies that weren't cell targeted were used. And they had massive iatrogenic effects. That's my second word. Iatrogenic effects means morbidity and mortality may be caused by a medical intervention. Lest we vilify those therapies at the time were the best that we had, but we have better now. And the healthcare providers, the settings that deliver these important therapies, the great hospitals of our state, they're confronted with providing the infrastructure and the setting and the environment to deliver these important therapies. That's an important precursor to the understanding and interpretation of that information. It reflects evolution and innovation, and would be remiss to try to think that it's just sheer arbitrary cost increase. It makes society better, and it makes our healthcare system better. Our task today is just to share the information, but there's sometimes and lots of opportunities in and along the way where we have to contextualize it for you so that you leave here with the interpretation that we'd like you to. That is all of us together working to make it better for citizens of our state. But those are important summary statistics that are at the top of our model. And I refer to these as the macroeconomic metrics that we're presenting to you today. In the interest of making this interpretable for all people that live in our state, that sit in this room, or that are anywhere else in this great country of ours, we produced this utilitarian metric somewhat in response to, my disenfranchisement on the pie chart and the donut charts, not just because of their names, but because of some logic issues that lie in the graphic in of itself. We don't buy healthcare with pies or donuts. We buy them with dollars and cents. And it turns out, just like the pie chart, which is great to divide 100% of something into partitions, a dollar, implicit in the name, is made up of 100 what? Cents. So 1 cent is 1% of a dollar. So it's a perfect graphic because it's contextually relevant and it's comprised of 100 units of money to break this up into an interpretable metric we call the New Hampshire Healthcare Dollar. We're proud of the work that went into this. You know where most of the work was centered around, and we hope our citizens can look at this and have an understanding for where every cent of their hard work earnings go to. That's important. It's a utilitarian metric. This is our second permutation of this. We have New Hampshire Healthcare Dollars for 2021 and 2022. We refrain from presenting that to you today because we have much better confidence, stronger confidence in the precision and accuracy of the 23 and 24 total healthcare expenditure estimates that we're presenting to you today. We welcome your feedback on that. So we talk a lot about healthcare affordability, and you know, I have a lot to, and a growing interest, a lot to say about healthcare affordability, what frameworks we use to define affordability, who it applies to, what it applies to, and how it applies to it. And more on that maybe in the fall. But sufficient for today will be to share with you different permutations of the measures we just reported in comparative metrics. So a lot of states that use the ballot model to publish the total healthcare expenditures, they compare that total value in the per capita value against state gross product. There's not any one universally accepted macro or microeconomic measure to compare it to. Given that, we've chosen to compare it to a lot. That decision is not taken lightly and is highly influenced by economists in the state. One of them sitting right here, Phil Sletton, informed us of other ways to express these data that are more contextually relevant than looking at a measure of state economic output. And Brian Gottlob from New Hampshire Employment Securities also gave us great advice. And you're about to see reflections of that information and those viewpoints and perspectives, which are examples of holistic representation of how we present the data to you. You know, Commissioner Bettencourt does not want these metrics just to be the way the insurance department looks at it. How do other economists look at this? How do they think it should be expressed? That's important, and I'd like you to hear that. I hope you hear it. I know you listen to it, but I'd like you to hear it. And hear that you have an opportunity to reach out to us, to meet with us so that we can find out of other ways to express this that would be useful for your work. So what's interesting and why I am, despite some of the limitations, I am a fan of reporting the total healthcare expenditure as a function of state gross product, not adjusted for inflation, is because total healthcare expenditure is in of itself a macroeconomic concept. It's about 15 to 20% of expenditures, which makes it that. Macro means big, right? Any economist knows macro, micro, and then macro, micro. It's like this coursework sequence, right? Macro means big. What are the big players and what government and what we spend our money on? Milton Friedman called it the income expenditure model back in 1968. It became ubiquitously used in the early to mid 70s to how we measure our economy. To this day, it's how we measure our economy. It's called the income expenditure model, and I wasn't even thinking about this until I talked to Phil on email yesterday or the day before. Income expenditure, what we take in for income, we spend. That's how you measure the economy. So what do we spend it on? Consumption. If we don't spend it there, what do? We invest it, savings accounts. And if we don't invest it, we pay taxes, government spending. And there you have it. That's what makes that a supreme model, and that's what makes New Hampshire gross state product an excellent macroeconomic comparative point to compare a massive chunk of expenditure for New Hampshire citizens too. And there you see it. But lest we forget, there are other metrics, like comparing that against household income. Thank you, Phil, right? So we do that right here. You can see as a share of personal household income, how does healthcare compete with these other things we spend our money on at the household level? That's important, right? Because we hear this, like this euphemistic, but real and important and really powerful, and sometimes I think sad. I think anecdote's the only word I have right now, where, you know, Mrs. Jones didn't fill the prescription for her important medication, comma, because she couldn't afford it. And that's important when we think about the complexities of understanding, truly understanding affordability. Because what displaced that expenditure? Was it something non-medically related, like housing and heat? I wouldn't, you all might be tempted to put food in there, but because I believe food is medicine and a really important one, I would say that comparison suffers mightily from multicollinearity. That's my second word, or is that my third word? That's my third word. So that issue suffers from that, but how it competes with other household expenditures is key. And that's important to understand that. But here we report similar shares using both metrics. That should cast insights into the utility of that comparison for everybody here. That's not a coincidence. That the share of expenditures for healthcare by state product or by personal income is almost the same. It also tells us that Milton Friedman was still kind of right with his income expenditure model. So let's just go quickly here. These are all in our chart book, but what about state comparisons? Now these are using different total cost of healthcare metrics, the National Health Expenditure Accounts, which are those indirect measures I was talking about, but they're very suitable for ranking. Why? Because they're germane to all 50 states. Recall that only 8 states measure total cost of healthcare the way that we did. You can see here for 23 on the top and 24, New Hampshire's doing pretty good and better in 24 than 2023. And we have that isoquant bar, that static reference line. That's the national average. I wanted to put this in here, even though I still feel like, and you may feel that it's out of context, provider access. These are from the BRFSS, which is a very, very reliable population representative survey data set. And it shows here, and I'm proud to have seen this, and I was unaware of this until about a week ago, that with regards to the percentage of adults with no personal doctor, New Hampshire ranks #1 in the nation at the lowest percentage. I did not know that. I think that would be remiss to not point that out to you, and I'm really proud of that. You can see the national average is 17 and I think 16% respectively for 23 and 24 on that front. That's really good. For a state that's very largely rural like New Hampshire, that says a lot. We do a lot of policy work and access to health care, and I was surprised to have seen that. I want to share with you. And importantly, the data source there is a very reliable one which is indeed population representative. Okay, so this is our New Hampshire chart book. The QR code that you saw prior to the onset of our presentation, and you'll see right there, is the way to access it. It's on the NHID website. It's on the back of your agenda. you can't have encountered us today without encountering that. It's important. It's an efficient way to deliver digital information, and you can take a screenshot of that, and it's on your cell phone. You can't escape it, and we'd like that. So we report in several different, what I think are rather awkward lenses and terms. We call them units of analysis. My team is still in the early processes of warming up to those phrases, but that's what they are. At the line of business level, Medicare versus Medicaid versus commercial. At the market segment level, which is really important to our work, individual market, on and off exchange, small group, large group, that's the market segment level. It's site of service, where does the healthcare delivery happen? Inpatient, outpatient, independent clinics. The measurement terms that we use, we report lots of healthcare utilization metrics and cost metrics. They're distinct from each other. Until very recently, and I learned this from Deb Fornia, that especially on the wake of the COVID pandemic, it was the, how's it say, I don't want to say it wrong, but it was the price is stupid. This paper, I'm not saying that, it's the title of a paper that it wasn't utilization that was driving up healthcare costs, it was the prices. I can't believe that paper got published with that name there, but it's kind of it rings a little bit. But now we're seeing something different, that prices are up, but also now the story is, in the last 2 years especially, utilization is also up. So when we report utilization, we generally, and Matt's done a lot of work here, Matt Jeffrey, with the utilization per 1,000 members. It's a standard way to refer to it. I'm still myself warming up to that, but when you see them in their graphical form, I think you might appreciate that standard approach. For cost, we talk about it allowed amounts. We express them per member per month or per member per year. One caveat to that, allowed amounts is equal to the paid amount plus cost sharing, out-of-pocket payments for the citizen, the member, which means that when we think about PMPM or PMPY, that is not just sequestered to premium. That's really the cost exposure with premium and out-of-pocket payments, because it's derived using the base metric of allowed amounts. That's important. We have difficulty communicating that in our fiscal impact statements into the legislature because it's not as straightforward as 4 letters and give me a number. Healthcare insurance plans are designed very heterogeneously, I did not exceed my limit, with regards to this balance between premium and out-of-pocket maximums. So we can't just say, well, what's going to be the premium impact? We'd rather say what's going to be the fiscal impact in terms of per member per month or per member per year. But what's endogenously embedded in that is the out-of-pocket payments. That's important to know, and that's a long but strong caveat. So here's some utilization metrics. I'm getting late in time, and these are all in the chart book, and you probably can see them better in that output, but here you see them. These are, so we measure utilization for key domains because they're of policy relevance. Inpatient admissions here by market segment for 3 years, 22, 23, 24. I'll move on to emergency room, or we call them ED encounters. Same years of interest, same market segments of interest. And you can see that from the period of time, note to interpret these tables here, the black reference statistic with the plus sign is the 3-year trend. The values in the bar are that year's absolute value with regards to the metric of interest. Retail prescription drug utilization right here, so prescriptions per 1,000 members. We have them transformed, and again, Matt has done this for better contextual interpretation, right? Because you can look at this, average annual prescriptions per member. At first, I was lukewarm on doing that. Now I see why he thought it was a good idea to do that. You know, just looking at the individual off exchange 2024, 15.7, what? Prescriptions per member per year. That means just over 1 per month. That, okay, wow. There's not a lot of people, if you look here in the commercial markets, that don't fill one 30-day supply of a prescription in a month. I did not know that until Matt encouraged us to represent the data that way. That's important. We welcome your feedback on that. But here you see growth in that in utilization. We saw growth in utilization of all 4 of those domains of healthcare that are of policy relevance in the commercial fully insured markets. Primary care visits. The utilization is up in all markets. It's up from 23 to 24, which is the biggest increase, but it's up since across all 3 years of interest too. So every year we're seeing an increase in utilization. We don't go so far as to do causal inferential analysis to say what's driving that. Because that's another story. There's a myriad of different usual suspects that we might consider. That's beyond the scope of this presentation. Remember, transparency is the scope of this presentation. So now we go to costs. Those 4 utilization metrics, they're not only New Hampshire, but Massachusetts Health Policy Commission measures that. Rhode Island Office of the Health Insurance Commissioner, they measure that. I didn't understand why until I got deeper and deeper into this work. Now I understand about half of why. So we express the primary care costs in this line graph so you can see the cost trajectory a little more lucidly across all market segments. But we just wanted to point out that it's going, these are costs now. So utilization of primary care is going up. Indeed, also the cost is going up. It's important, and Chris White from the University of New Hampshire is here too. He's working hard, and he helped us understand much about the complexity of defining and measuring primary care. How do you measure that? Anyone who's ever gone to a doctor, like a cardiologist, could give you a vaccination, and a primary care doc can give you an EKG. You see that it's not as simple to say, well, what's the provider type? Is it a primary care provider? Because they provide specialty care. Oh, is it a specialist? They provide services that we might otherwise classify as primary care. And I was the last on the list of people who were aware of that at the onset of endeavoring to do this work. And so it's not nefarious at all to think that, wow, utilization is going up, and so is cost. That may be nothing merely more than a reflection of efficiency improvements, lest we indict that cost driver there. We've not gone so far to interpret it that way, what's driving it. But I gave you an example of what might be some plausible, rational reason why we might see that. We wouldn't want to censor improvements in efficiency, those which I really kind of just subjectively described one example of. We wouldn't want to censor those because we misinterpret these. And it's our responsibility to make sure we share it with you that way so that you don't fall subject to some of those same things that I've iteratively fallen subject to. Here you see some of that data expressed our standard way in a 3-year bar chart, same years of interest, commercial fully insured market, and you can see clearly that there's an undeniable trend towards increase in a lot of amounts for primary care. Maybe we're just being more thorough in those settings. Maybe it's something other. We can have that talk another day. Retail pharmacy claims. Now, important to note that these are 2025 data using claims, the CHIS, New Hampshire CHIS. We're proud of that data. Very powerful data set. I don't know that I could have gotten through this talk without having at least one robust reporting metric from the CHIS here. So here you have it. Here we report total retail drug spend partitioned by two key new sets of drug classes, really. GLP-1s, and this very, very, very extensive and broad range of behavioral health substance use disorder drugs. Why are those in there? Because some of them are not new, many of them are new, but what is new in that space of therapies is demand expansion in improvements with access to care. And I know Commissioner Bettencourt has worked vigilantly, and so has Michelle Heaton and a lot of other team members, Lee Curtis is here too, have done a lot of work to expand access to behavioral health substance use disorders. And it turns out that pharmacologic therapies are the most ubiquitous, I went over my limit, the most ubiquitous therapies for that population. So that's why they're in there. And you can see across now, here we have lines of business, commercial, Medicaid, MCOs. What you see here for Medicare is Medicare Advantage. Traditional Medicare or Part D is not in there. And then it's all combined to the right. But you can see that, I think Matt came up with 17.5% on average of the retail drug expenditure is attributable to GLP-1s and drugs that treat behavioral health, substance use disorder conditions. And that's important to know. I thought someone would ask a question about that. I'm kind of glad you didn't. Right here now, we just, we're in a secular lens, GLP-1 utilization. GIP, they're analogous in a way. They're different substances, similar allosteric targets. Here you see growth. Don't mistake the inferences behind that chart. Innovation and regulation, two things near and dear to the heart of economists. Innovation, new discoveries, right? Regulation, FDA approval for a new indication. Those are two things that drive up utilization and cost. You're seeing that right there. It's important for me to help you interpret it that way. It's not that something nefarious is going on here. Here's expenditures. You see that despite utilization going way up, wouldn't you expect to see the same trend in the cost? Here you're seeing this expressed as average cost, not absolute cost. But what we also know happened in 2025 are a lot of close substitutes entered the market. What are those? Generics and alternative delivery formulations, oral substitutes, and competition. Taken together, there is already a remarkable attenuation in the cost incursion in this important drug therapy. I've shifted my viewpoints on how I talk about these a lot because of that. That's markets working right there. We need more of that in our healthcare system. Markets working, helping people get more affordable access to these therapies. I myself have a little bit of a challenging time here. We endeavored to show you in the behavioral health substance use disorder care delivery paradigm how by market segment and year those deliveries are partitioned. The cost of those deliveries are partitioned. And you can look closely on this on your electronic version. I have to zoom in with my lens here just to make sure I'm looking at it. So here we look at pharmacy, professional, facility claims, and non-claims payments and other claims, which represent a lot actually of those. And you can see partitioning, and you can see just trends from year to year that vary by market segment. Contextually, there's a lot going on there, so if you need help interpreting that, then two things. You're just like me, but we can also help you if you reach out to us. There's a lot of holistic market and condition-specific information embedded in there that confounds the direct interpretation. Here we express these dichotomously, where now we're looking at by provider type, how are we delivering healthcare to our citizens? And this is again an example of why we partition provider type into physician provider, non-physician provider. Because we've heard it, I think everybody in this room's heard it, that we have a shortage of behavioral health substance use providers in the state. And that shortage, it actually is worsened by rurality. As you get to the more and more rural areas of the state, that shortage has a more remarkable impact on access to health care. So we kind of wanted to know what the composition was like with regards to provider type, physician versus non-physician. The dark blue on the top, you guessed it, is non-physician provider type. Those are providers delivering behavioral health services to our citizens that are not physicians, DOs or MDs. And there are a couple of other subtypes I might be missing, but physicians. The lighter blue metrics of physicians, but you can see the lion's share of healthcare services delivered for behavioral health substance use disorder conditions are delivered by non-physician providers. You could look at this and say, wow, something's gone awry. What are we doing that's not right? I look at it in an opposite lens. I'm saying, good job, New Hampshire policymakers. Good job, hospitals. I always get the acronym wrong. FQHCs? FQHCs. Good job getting services to citizens using adaptive resources that state policymakers have already put into place, broad scope of practice for non-physician services, payment parity, preface to Commissioner Bettencourt's policy message coming sooner than later, Jason, right? That's innovation, that's adaptation, because I think of it this way. What does our healthcare system, what's it supposed to do? How is it supposed to serve us? By taking people with names, homes, jobs, souls, with family members, and getting them access to the important healthcare services that they need, versus these titles and frameworks that have long ago gone awry. That, to me, says stuff is working. And let's keep on that track with regards to that specific domain of a constraint that our great state, our very rural state, suffers from differently than states like Massachusetts and New York. Good work. So this is that same service category, behavioral health substance use disorder, with regards to site of service. The dark blue on the top is outpatient, the light blue on the bottom is inpatient. I'll say little about that, but that's where those services are getting delivered. Much of the interpretus of this is beyond the limits of my knowledge, and most of you here probably have a much stronger and deeper acumen to make sense of that. Okay, wow, I thought I was going to be a lot more over than that, and I was rather more verbose. But we welcome any questions. Maybe this is preceding what Commissioner Bettencourt is about to share with you. Germane to these metrics that we worked hard and for a long time to deliver to you, what are some examples of policies that we might endeavor to consider to help address some of the issues that we're, I think, alarmingly aware of? With regards to what the things that I talked about, how we measured total healthcare expenditures, how we scrutinized over the populations of interest, and ensuring that we could stand up here in front of you with great confidence and tell you that these are very population representative of the New Hampshire citizenry, and then all the metrics that followed, the ways that we compared them. Do you have any questions for me or for my team with regards to that? And yeah, so Chris White from UNH, who has helped us with some of this stuff.
You had mentioned net health insurance costs. Is that basically administrative fees and profit?
Yeah, it's very similar in construct. So Chris asked about the net cost of private health insurance. I made a mistake and thought, and I talked to Morgan Harris about this, because she derived those metrics. And she went, should we take the P out, net cost of private health insurance? Should we take the P out? Because, you know, what about the public health insurance? Turns out there really aren't metrics for that in the New Hampshire Medicaid metrics that we derived, and the traditional Medicare metrics or the Part D Medicare metrics. There are for the Medicare Advantage metrics. Am I right about that, Morgan? So it turns out Medicare Advantage plans, they use private health insurers to administer those. So it is aptly named when we say NCPHI, net cost of private health insurance. It's essentially the calculus is, it's the total premium collected minus claims. That's the calculus for that, which equals what Chris White just said. It's the administrative cost of providing healthcare financing for our system, our great system, our greatest in the world system. That's important. And it's noteworthy for 23 and 24, those values were the same, about $500 million for both years. That's how much it adds to the cost. Lucy, did you raise your hand?
No, how different is it from the MLR?
The MLR is distinctly different, but it's the same construct, the same idea, but the calculus is different. For example, the MLR is smoothed over 3 years. It's actually not the weighted average. It's more like arithmetically, it's the geometric mean across 3 years of that idea. Because there could be, you know, there's a lot of big firms want to innovate. Oh, we got a new system, or we've got a new building that has all of, you know, we've made it more efficient. And if you were to have a secular approach to requiring insurers to have MLR for 1 year and that's it, you would penalize firms that want to invest in those efficiency gains. And if you think about it that way, that wouldn't be right. And then there's other market dynamics too that cause fluctuations. Maybe a bunch of members in these one type of plan got sick and they incurred a massive claims experience that year. So the MLRs are smoothed out over a 3-year period. Very similar arithmetically to what deriving a geometric, there are two types of means, arithmetic and geometric. It's more like a geometric mean. That's not meaningful to you, but it's just pointing out the distinction between the two, which is an important one. That's a hard thing to understand, the medical loss ratio and the MLR rebates. And there is indeed a non-trivial amount of misinformation on that. We hope we can help people understand that very complex but important metric better. Yeah.
I mean, well, in practice, payers use medical loss ratio all the time for years and for quarters and all sorts of things like that. So it is something that's used in much smaller intervals than 3 years smooth. I mean, it's, you know, say this is what our MLR is for this quarter, this is what our MLR is for this year, this blah, blah, all those things. So that's, for payers, it's used in much smaller intervals than 3 years.
Yep. Good, thank you, and that's a good comment. I appreciate you pointing that out. And so in the interest of clarity, what I was pointing out, to derive this kind of framework for the MLR rebates, CMS smooths it over, so the Center for Medicare and Medicaid Services smooths it out over 3 years so that they can derive values to base the MLR rebates back to payers on. Lucy?
So thank you for this.
Yeah.
It's evident what incredible amount of work your team has done on this.
Thank you.
Just a question, do you plan in the future to do a deeper dive on pharmacy, given there's there's mail order and there's obviously, healthcare based pharmacy that is a big part of that may show trends over time. Do you plan to look into that?
Yes, we do, and this, that plan can be largely influenced by Lucy Hodder and the team at UNH. We want to hear from you. What types of analyses would help improve the utility of this information? Oftentimes I fall frustrated in that we have such rich information, we want the utility of that to go up. So looking at alternative types of analyses and other ways to express these data or dig deeper and do other analyses, we have, and Commissioner Bettencourt is very clear with us that we have lots of assets that can enable those insights and create opportunities for policymakers and stakeholders.
On that note, just to elaborate a little, if we focus on medical pharmacy, particularly infusions, J codes and the like, to pull that out and the site of care related to that, and make a distinction between who owns the outpatients. Where that's a particular place.
I appreciate.
So that's an 800-pound gorilla that I haven't heard.
So just thank you for bringing that up very much. We did work on that. I'm not sure if Maureen's still in the room, Maureen Brooks. We looked at the medical pharmacy. So the pharmacy spend under the medical benefit compared to the retail pharmacy. And frankly, I was expecting to see a much bigger proportion of spend in the medical pharmacy. It averaged about 10%. But that, when you're talking about 17 to 20% of the total healthcare spend for prescription drugs, 10% is a massive value. It's hundreds of millions of dollars. We didn't include that here, but we welcome subject matter expert feedback on that area on how to organize analyses to help communicate the importance or just the existence of that there's an increasing share of pharmacy spend that's falling under the medical benefit. We actually, I at least for one think that's good, but we need help formulating it in a meaningful way. So please do. That's, I think, the third or fourth time I've almost reiterated that. Please do reach out to us to help guide us. We want to hear from you. I want to hear from you especially. Hi, Steve.
Hey, good morning.
morning.
Thanks for the presentation. You talked about utilization ticking up. We've been tracking inpatient utilization or inpatient capacity at hospitals since the pandemic. We're consistently, last week we were about 95% occupied across all hospitals in the state. That's something we've seen certainly that high a level during respiratory virus season, which we're not in today. We're seeing more patients that are sicker, requiring more interventions. There was a study out of UCLA about a year or so ago that said hospital capacity nationwide since the pandemic was about 75%. We're consistently well above 80-85%. So would be curious as to sort of the metrics that you're looking at for utilization, because given our aging state and demographic, we're certainly seeing that very, very real time.
Sure, yeah. So note that our utilization metrics are in the commercial fully insured markets, but we identify 4 key domains for utilization. So retail prescription drugs, which I think falls under the insights the important message you just shared. Primary care, which that's really more of an outpatient construct. Then inpatient admits and ED visits, which I think fall under the guise. But there's probably a lot more things driving the utilization trends. So you're saying at hospitals utilization is up too, right?
Absolutely.
Yeah, and that doesn't surprise me because we have 2 surrogate measures of that with the IP admits, inpatient admits, and the ED visits, which I don't know what the proportion of ED visits turn into admits, but I'm certain it's not 0.1. So there must be a litany of other types of morbidity burdens that are driving. You mentioned one, the elephant in the room, right? But there's got to be a lot of other factors driving the utilization. And that's another example of we welcome integration from your data analysts at the Hospital Association to incorporate into these guidebooks. These 4 standard utilization metrics fall inside and out of hospital utilization trends. And so they're really at the payer level, what we're seeing. We'd like to know more at Great New Hampshire hospitals, both inpatient and outpatient, what are some other utilization trends you're noticing? Because the commercial payers, cover a lot of those services. And that's the purpose of the data submissions for these metrics that we shared with you with regards to utilization. That's an important adjunct to the message we shared about utilization. I'd love to know more about that. Deb Fornia, I see a hand.
Jason, why don't you do the last question here? You're real sharp.
The very last statistic you shared, which was that allowed amounts for behavioral health decreased.
Yep.
It was on your last slide, the very bottom. Yes. Proportion of allowed claims for inpatient facilities for behavioral health decreased. Do you have any more data about that or explanation?
We have the data. The way we express this is the proportion of the total allowed amounts under the facility that's attributable to outpatient versus inpatient. So these are crude proportions, but that are bifurcated to two levels. It doesn't look at the absolute cost. We do have that data. So Senator Rosenwald, please reach out to us so we could put a table together for you so you could see that in per member, I think it's per member per month values for that.
If I could ask another question.
Yeah.
Are you able to get managed care organization Medicaid data for all this stuff that you did?
We did, and that's for these metrics here. We're not reporting on the MCOs that provide services for New Hampshire Medicaid. In the total healthcare expenditure metrics, you do see as an aggregate that, and we're very sensitive to not report at certain levels outside the areas of our regulatory authority, and that was one of the things that Commissioner Bettencourt touched on. But we get the MCO data, and we have a strong awareness of what that looks like. Please reach out to us. I think we're out of time. I know Deb Fornia has a real quick question. Can I just do Deb's quick question?
Similar to Senator's question about, are there visuals of the utilization and allowed amount for the other compartments for Medicaid, Medicare, and the self-insured? Can we see those?
We can, let's meet and we can add those to our chart book. We're going to be updating the chart book this summer with 2025 data from our annual hearing data call. And we want it, I've asked for that many times now, so I'm expecting to meet with your team. We meet regularly with Deb and her team.
Not just the fully insured, but across Medicare, Medicaid, and self-funding.
Yeah. Let's do that. Okay, thank you so much for your time, your interesting, frankly, riveting questions. Now, Jason Dexter is going to come back up and then introduce Commissioner Bettencourt's message that should cast lots of insight and maybe operationalize some of the stuff that I talked about, the things that I talked about. So thank you for your time and your interest, and I hope to see you around in our endeavors. Thank you. Thank you.
Thank you very much, Jason. Appreciate it. I'll be brief. One thing I just want to point out, I said earlier that we had an idea when we put this together 7 to 8 months ago, and the majority of it came together really well. There was one piece of it, and it was kind of the original idea, was to have carriers that are getting ready to file rates come in here, come talk to us, sit on this panel stage, and talk about what they think is going to be driving rates for the upcoming year. They didn't think it was that attractive of an idea for reasons I think I can understand. Plus, we heard a lot of it's school week, it's school vacation week. So that kind of, we hope to maybe put something together like that in a future year. We think we would be interested, and we did get cooperation, but just in a way that we didn't feel was meaningful enough to bring them up here. So thanks for all who participated. I think primary point of Jason's presentation. I think the first portion is we believe in this data. We want you to believe in it. We want you to be able to use it to have conversations. And I think that's what DJ's message is going to be. So I will say this, DJ's message is about 10 minutes long. For those of you who know DJ, if you were here, he'd just be getting started about the 10-minute mark. So we're going to pick up some time with this message, but here we go.
Good morning again. Let me begin by saying how much I appreciate the work that brought us to this point. Both the discussion we've had today, and in particular, the Healthcare Data Chartbook that my team has put together. It is a serious piece of work. It reflects long hours, careful analysis, and most importantly, a commitment to letting the facts speak for themselves. Because at the end of the day, that's where good policy starts. Not with assumptions, not with anecdotes, but with a clear-eyed understanding of what is actually happening in the healthcare system. And I want to thank in particular Dr. Jason Aziz, the Director of the Department's Data Analytics Unit, and his team, including Morgan Harris, Maureen Brooks, and Matt Jeffroy. They have done absolutely phenomenal work, and today's forum would not have been possible without their incredibly hard and diligent work. So thank you to that team. Now, if you step back and look at the data we've presented today, a few things become evident. First, healthcare costs are not being driven by a single factor. I mentioned that before. They are the product of many moving parts. How care is delivered, how it is priced, how it is paid for, and how it is used. That means there is no single solution. Second, the data shows variation, real variation, across sites of care, across providers, and across services. And where you see variation like that, you have to ask a basic question. Is that variation tied to value, or is it simply a function of how the system has evolved? That question sits at the heart of several of the policy areas I want to discuss with you today. Let me start with site-neutral payments. What the data makes clear is that the same service can cost more simply because of where it is delivered. In particular, services performed in hospital outpatient departments are often reimbursed at higher rates than those same services performed in physician offices or other non-hospital settings. Now, I want to be very, very clear. This is not a criticism or a critique of hospitals. Hospitals play an absolutely critical and essential role in our system. They handle the most complex cases, they provide critical care, they offer critical access, and they are foundational to community health. But not every service requires that level of infrastructure. And when services that can be safely delivered in lower cost settings are consistently reimbursed at higher hospital-based rates, we create a structural incentive that drives costs upward over time. Site-neutral payment policy is, at its core, an effort to address that imbalance, not by cutting indiscriminately, but by asking a simple question. Where is it appropriate from a clinical standpoint to align payment with the setting of care? Medicare has already begun to move in that direction. Many states are exploring similar approaches, and I believe it is an area where thoughtful, carefully scoped policy could produce meaningful savings without compromising quality or access. Closely related to this is the issue of outpatient facility fees. As the data shows, outpatient facility fees now account for a significant share of overall medical spending, roughly a third in some estimates. These are charges that often arise when physician practices become affiliated with hospital systems, and the billing structure shifts accordingly. Again, the point here is not to assign blame or to be critical of anybody. These arrangements often reflect broader changes in the healthcare landscape. But from a policy perspective, we have to ask whether the current structure is producing the right incentives. Should a patient pay more for the same service simply because of a change in ownership or billing designation? That's the question that site-neutral reforms and facility fee policies are trying to address. And I think there is room, carefully and thoughtfully, for us to engage in that conversation here in New Hampshire. Now, let me turn to provider payment reform. New Hampshire, in many ways, is ahead of the curve in this area. We have a broad scope of advanced practice providers, APRNs, physician assistants, and we have begun to see discussions around payment parity. The data shows that non-physician providers are often reimbursed at lower rates, sometimes significantly lower, even when they are delivering services within their scope and at a high level of quality. Now, this is not simply a question of fairness. It is a question of access and efficiency. If we want to expand access to care, particularly in underserved areas, we need to make sure that our payment structures support the full use of our healthcare workforce. At the same time, we need to be thoughtful. Payment policy should reflect training, complexity, and the realities of care delivery. But where there are opportunities to align incentives in a way that expands access without driving unnecessary costs, we should take a closer look, a much closer look. Another area the data points us toward is prescription drug spending. Roughly 1/5 of total medical spending is tied to prescription drugs. And within that, a relatively small number of high-cost drugs account for a disproportionate share of spending. Fortunately, there are a number of policy tools being discussed nationally and at the state level to tackle this challenge. Things like most favored nation concepts, international reference pricing, and indication-specific pricing. Each of these comes with trade-offs. Each raises legitimate questions about access, innovation, and market dynamics. But what the data tells us is that doing nothing is not a sustainable option. We need to continue exploring targeted, carefully designed approaches that can bring greater discipline and transparency to this part of our system, particularly for high-cost therapies where pricing can vary widely. Now, I want to touch on an issue that does not always show up neatly in a chart, but is very much present in the data if you know where to look, and that is market consolidation. Across the country, and here in New Hampshire, we have seen increased consolidation among hospital systems and provider groups. There are reasons for this. Some of it is driven by the need for scale. Some of it reflects the complexity of modern healthcare delivery. But consolidation has consequences. It can reduce competition. It can increase negotiating leverage. And over time, it can contribute to higher prices without a corresponding increase in value. Now again, I want to be measured here. Consolidation is not inherently good or bad, but it is something we need to watch carefully. And one of the challenges we face is that we do not always have the data we need to fully understand market dynamics, particularly when it comes to market share and affiliation. That's why proposals around hospital market transparency, which is the requiring of timely reporting to encounter data, for example, are so important. You cannot manage what you cannot measure. If we want to have an informed conversation about competition and pricing, we need a clearer picture of how the market is structured. Finally, let me speak about something I believe very strongly in: alternative payment models. If there is one area where I think we have a real opportunity, it is here. Our current system is still largely built around paying for volume, more services, more procedures, more utilization. Alternative payment models, whether it's bundled payments, shared savings arrangements, or other value-based structures, are designed to change that equation. They aim to reward outcomes, coordination, and efficiency rather than sheer volume. Now, these models are not easy, I know. They require alignment. They require trust. They require a willingness to take on risks and to think outside of the box about care delivery. But they also offer one of the most promising paths forward if our goal is to improve quality while bending the cost curve over time. And I will say this clearly: I am a strong supporter of continuing to explore and expand these models in a way that makes sense for our market. So where does all of this leave us? It leaves us, I think, in a place of cautious but real opportunity.
I think that's a great message. There's a whole almost market basket of different policy examples. And again, germane to the Commissioner's introduction, our role is to provide information and incorporate all actors and stakeholders and policymakers in the development of the process of delivering that information. We want a fair and he said like cautious opportunity, cautious, I think I paraphrase, optimism. You heard examples of policies that exist in other states. There's that idea of what are other states doing. We look a lot at the National Academy for State Health Policy, NASHP. One of their primary approaches is to have these spreadsheets with all the states and what have they done with regards to some of these key healthcare policy targets or categories. He shared a few of them that have been recurring themes. And as a note, the Insurance Department is a state agency that I'm proud to be a part of and does important work, but we're not policy makers. We see ourselves as purveyors of sound, reliable, valuable, insightful information to all of the policymakers, but also industry and stakeholders who perform important roles in healthcare delivery. That said, does anybody have any specific questions on some of the messaging that Commissioner Bettencourt just shared with you? And maybe we can opine on that in the event that we get an inquiry that we're not able to. We can confer with Commissioner Bettencourt early next week or later this week, as soon as we see him, and produce a written response to those inquiries. Hey there, what's your name?
My name's Sarah Bird.
Hi, Sarah.
And I noticed in your charts that the off-exchange utilization is growing faster than a lot of your other markets, and wondered if the New Hampshire DOI or any other government organization has considered its own exchange rather than using the federal exchange.
So that, Sarah, is a really good question. That's beyond the limits of my understanding. So Michelle and Jason are here. They can help me with that. And I'm always happy to say that it exceeds the limits of my knowledge in that area. Michelle Heaton is our Life and Health Director. When anyone, myself included, has any questions about markets and health insurance and those types of things, they know right where to go, and that's what Michelle's going to help answer for you. Thank you, Michelle.
So we have done some work on considering a state-based exchange. In order for that to actually occur, there would have to be a legislative change, and so at various points over the years, it's looked more attractive for various reasons. But our most recent analysis does not favor doing a state-based exchange. Because some of the fees associated with it, it would be a huge undertaking for our state and our department to actually have to build out an exchange. Right now we are on the federal platform, and so there's a lot of cost savings there for us. So the math doesn't quite add up there. Another thing that helps bring down overall health or overall costs for the individual market is our 1332 waiver and our reinsurance program. And so that is another thing that they're a little bit different, but it is something that we've had a lot of great success in bringing down costs. And so when we do our analysis, part of what we would get in funding from the feds fluctuates year to year, and based on our enrollment, the numbers just don't quite add up right now at this point in time.
Any other questions? Don't go far, Michelle.
Right here.
Hi there, what's your name?
Laura.
Hi, Laura.
I'm board member for St. Joseph's Hospital, but also a nurse. And so, of course, I listened to this with that clinical caregiver kind of paradigm. And I was just, in terms of Commissioner Bettencourt's, suggestions, the areas to look at, which were very interesting. Just one, in terms of site variation around care delivery. Less expensive sites versus like more expensive sites, hospital sites. One of the biggest growing populations is our elderly population. And while we've got the Medicare Advantage factored into your data, there's a great deal of folks still with traditional Medicare. And so when I think about something like that, I think that data would be really important, because we know elders have more comorbidities or potential risks. And so therefore, the same procedure that a 50-year-old male would get versus a 75-year-old male, say a hip replacement, we would consider the site in terms of the added health needs. So I just wanted to throw that out there for your thoughts on that.
Yeah, I have many thoughts on that. Thank you. It's an excellent insight, and I'm glad everybody sitting in this room got to hear that, because that's important. So just as a mechanistic response to what you're saying, I'm certain the commissioner is going to ask our unit to do an analysis observing the variation in cost with regards to site of service. And without question, there's an endogeneity issue with that, meaning it's probably true that the more acute cases go to the more acute clinical care settings like hospitals, and that could be a driver. So the metric that I would control for in that analysis to make sure that clinical acuity was not the underlying cause is the Charlton Comorbidity Index. You just list comorbidities on an ordinal scale, and the more there are these cut points, like 1 to 3 comorbidities, you're a certain sickness. 4 to 6, you're sicker. So across the continuum of the Charlton Comorbidity Index, you're sicker. Does that explain higher costs or other factors? So controlling for comorbidities would be done that way. You can tell I've done that work before and thought of it, and it is an example of the responsible and transparent work we do with data to not just give an answer to a question, but to make sure that we give the right answer to the question. And you heard Commissioner Bettencourt say it almost the same way that I said it, because I feel the same way, but also because I watched his video yesterday twice. But we want to make sure we support the important work of that the hospitals do in the state, treating our older adult populations. And I have a new colleague here that works in aging. My entire career has been in that. So we don't want to disseminate misinformation by not controlling for the factors that these perverse factors that might explain why there's a variation in site-specific payments. It's important, and thank you for asking that, because everybody else not only heard that, but they got to hear how seriously we take mechanizing those analyses to answer those important questions. And the trust that I want this audience and others in the state to have, that we will make sure we are rigorous with that regard. And we don't come up with any old answer. We try to come up with a minimally biased point estimate that shows the righteousness of the information. Is that for you? Or? Hey, Deb.
I have a really almost a logistical question. Is the insurance department going to pursue a menu of these policy options that were suggested? Or?
Maybe Jason can help. I think I say it this way, and I'm rather almost purposely naive to the process. We're not a policy agency. We get asked a lot to inform the legislature and the subcommittees, and you can tell. I think you could probably tell that I take it very seriously, giving them the right information. It weighs heavily on me, Deb. And so, Jason, can you expand on that? Because I'm not quite sure how things end up being policy.
Right. So I think that the key point is, whether we like it or not, we get pulled into policy conversations. But we recognize we're a regulator, and it's so important. This whole conversation is about, we want to give the information and the data available so everybody who's talking about it can be kind of on the same page and think about those issues. We don't intend to file bills for these particular things, but we probably will get 2 bills from 2 different legislators on the opposite sides of some of these topics asking us to weigh in. That's typically what I see happen. And so we kind of have to do that balance of the middle of saying, here's the data, everybody's getting the same thing. And at some point say, you policymakers, legislators have to decide where you want to go. hard to balance, but that's, Jason, I'll
Hi.
give you
Hi, is it Mitchell?
One of the slides you showed how New Hampshire has been controlling the per capita cost of insurance, and we're in a different place relative to from 23 to 24. But yet the public feels that they still can't afford health insurance, and the costs are continuously impacting individual families and businesses. How do you reconcile that? How do you help the public, from your perspective, understand how they think about this? They're feeling the pinch, while you're saying, look, we're in a better place.
Yeah. So your first name is Mitchell?
Yeah.
Mitchell, nice to meet you. And I appreciate, Michael?
Yeah.
Michael, okay, thank you, sorry. That's a really good question. It's an important question. It's one that I've been pondering mightily over the last 18 months. I have certain viewpoints. Some of those exceed the scope of this meeting here. But we talk about affordability. It's a very complex term. I use that euphemism, right? Mrs. Jones didn't take her medications because she couldn't afford them. Right? I use sometimes onomatopoeia to say punctuation. But consider this hypothetical exercise. Across a continuum of medications for Mrs. Jones, are there some that she couldn't afford to take because other competing household expenditures were pressing and increasing at a faster rate? Or are there some medications in Mrs. Jones' market basket? We know that older adults usually have a lot, they're polypharmacy. That's more than 5 medications generally. Are there some medications in her pill box that she can't afford not to take? Meaning, what medications end up in her pill box? Let's not answer that question. Let's just consider that as the framework to think about affordability in a different context. We measure affordability now, and that's why it was important to have the right comparative metrics to share with you. That was step one in this process. The next step is to think about, what do we compare healthcare expenditures to? Rent, which we kind of can't do without that. Food, we could probably do with a lot less of it, but let's just frame it that we can't do without that. And other things in the consumables market basket, durable, there's a lot of things that we can't do. So it begins the question, what are healthcare expenditures competing with? Let's stop there and take a step back. And I would like to start considering, at least, and maybe referring to affordability within markets. What about the medication that Mrs. Jones is thinking, oh, should I get it? Should I not? I can't afford it because of all these pressing competitors. Rather, where can I get that same medication cheaper? We don't do that in our healthcare system. We are what we call price insensitive because we are indeed price unaware. But what that ends up resulting in is some sort of, for me, this innocuous vilification of the consumer. Should we have the right and the autonomy with my card? I have a card, any old card, give me that service. Or does the consumer have a responsibility to become price aware, like we do with gasoline, like we do with food, looking at the price labels? We just don't do it with healthcare. To sum a lot of that up, we need to make healthcare consumers more aware of within market price variation for that drug that they take. The GLP-1 example is a great example. In one short year, you see massive marginal cost decreases in that market because of the awareness, driven by popularity, interest, and all of that, efficacy, but you see a price awareness having an impact. Hey, wait, there's a GLP-1 oral now? Hey, wait, this state makes it available to their Medicaid patients, the oral drug, for $179 a month? Those types of, that example serves to show that price awareness works. We just need to do more of it. And the work that you're doing at the New Hampshire Health Cost Initiative is an example of building on that awareness. The work that we do with New Hampshire Health Costs, we agree, it can be, and we want it to be better, but it's an example of how operationalizing the price awareness will help to transcend our healthcare consumers to price sensitivity, which can then work. My point about the healthcare affordability is that I want to construct those comparative frameworks within markets, not across markets, because it's just not how price competition works. It works within markets. Just like gasoline, nobody goes and looks at the gas price, right? The level of variation for price awareness for gas is at what increment? Does anyone want to say what increment is the level of price awareness for gasoline? Hundreds of dollars? No. Cents? How many cents? 9/10 of cents. That's the level of price awareness for gas. Have you ever gone to a place and said, oh, their regular 87% gas is too expensive for me, I'm going to get diesel? You're going across markets. You don't do that in gas. We kind of do it in healthcare. Let's have other ways to express it. I've asked 5 times now. Express how healthcare costs at the per capita level compete with healthcare costs within markets, and we're on our way to having better price awareness and more price-sensitive healthcare consumers. That's, Michael, what I think I would love to work with all of the people here who I can tell have genuine interest in making it better for citizens. Mr. Annan.
Thanks. I heard the commissioner talk a lot about consolidation, spoke specifically relative to the health care systems. I didn't hear him talk about the consolidation of the insurance industry and the impact that has on the cost of healthcare. So I assume that was maybe that was what got cut off in the commissioner's comments, but I would love to hear your thoughts about that. I hope that could be part of the conversation.
So that you asked is we definitely want to take that back to him and offer. I will say this, that I don't think that was what got cut off, but there's more to that. Oh, you were kidding. I didn't know that. There is more to that. Consolidation for any markets. I've talked a lot with Commissioner Bettencourt about consolidation, and we understand that it's not just a New Hampshire problem. And I've shared with him this idea that it's really this Quixotan viewpoint that hospital markets should be a perfect competition. They're just inherently not. At the very best, even in metropolitan areas, they're oligopolistic. There's several firms like Boston, the healthcare mecca, Longwood Medical Center. There's like 3 or 4 firms that hold the whole market share. And we wouldn't expect that to happen in New Hampshire. But Commissioner Bettencourt is very aware that one, the hospitals, are inherently monopolistic by design. They have to be. Some of the rural communities cannot support more than one. We can't create a competition. Even in our metropolitan areas, Manchester and Nashua only supports maybe two. And that hasn't resulted in a level of competition that has been price containing. So there's a lot of complexities to it. I think that we would want to ask Commissioner Bettencourt to expand on that message and share that with the audience. And I'm hoping maybe my colleagues, Keith Nyan or Jason Dexter, can help guide me on that. It's a difficult response because we have a strong appreciation for that. And then we recognize tonight at 6 o'clock we'll be at Exeter Hospital for the Healthcare Commission, Consumer Protection Advisory Commission. And we understand, the Attorney General's office understands that we can't leave citizens without a hospital. And sometimes that appears like you hand over monopoly power, but
again, my point wasn't relative to the hospital.
And the same constraint exists in the health insurance markets.
So I just want to make sure that continues.
Yeah, I think the short answer is absolutely competition is good for the market. We're happy to look into that. Every single year when rates are filed, we always work with carriers to encourage that competition. We can't force carriers into the market, but it's something that we absolutely value. So thank you. That's a very good point. We can work that into future presentations.
It is worth pointing out, though, since we developed our 1332 program, so over the last 6 years, we have seen new carriers coming into our markets and increasing competition. And that's part of one of the goals for the 1332 program is to encourage more competition in that market, and luckily that's what we have seen in the program.
Hi, Matthew Hood, with Dartmouth Health. I really appreciate the information that was shared today. Thank you. And I was appreciative of hearing the Commissioner talk about the multifactorial nature of the healthcare cost conundrum. I guess the only thing that I would add to Mr. Ahmed's comment is in that spectrum of policy proposals, I didn't hear any about other players in the healthcare continuum. So I would recommend that if there are administrative challenges that healthcare providers face with carriers, whether it's prior auth or administrative challenges. And I think that goes to increasing the cost. So I would at least want to broaden the spectrum of the policy considerations that might be.
Thank you. That's some good input.
Thanks.
We do have 5 minutes left, so we'll take a couple more questions.
I want to know, will we have access to the Commissioner's statement somewhere that we can refer to?
We can make that available.
Sorry.
If you register, we'll email all these resources out to everyone that registered.
Thank you so much.
Thank you.
Thank you so much. If anybody comes up with questions in the next near future, you can submit them in writing. I think we had a slide for that. We'll share these slides, and on the last page we have the Healthcare Analytics website email address. You can submit questions in writing to us, and we'll get back to you, I think, within 7 days, and share all the other great materials that we worked hard to share with you. So we appreciate your receptivity to all that. Thank you.
So in closing, thank you very much for being here today. Kudos to Jason Aziz, his entire team, all of you for being here, and every policymaker that attended. So thank you very much.